Dr. Scott Neeley has been president and CEO of Sierra Nevada Memorial Hospital since March 2022, having served before that as vice president and chief medical officer of St. Joseph's Medical Center in Stockton for 9 years. He is a graduate of Harvard University, University of London, Stanford University School of Medicine, and the University of Massachusetts Amherst. Well, you haven't done much with your career, Dr. Neeley. I don't know. Thank you for coming. It's an honor and a pleasure to have you here because people are worried and people are unsure and confused about what all of this means to their everyday lives. So we'll take it down to the Nevada County residents, and we had a few statistics up above, but as I read online for the California Policy Institute, the number of children on Medi-Cal is 41,400, seniors 16,600, and people with disabilities 14,800 plus healthy adults. So that's a lot of people. How are we going to take care of these people if the money's not there to do so?
That's a great question. First, let me start off by just saying thank you for having me today. I know that this is an issue that concerns a lot of residents in Nevada County, and we have fielded many questions, basically along the lines of, are we still going to have a hospital?
Right. That's question number one, probably,
So question
right?
number one,
Mm-hmm.
We're still going to have a hospital. The impact of H.R. 1 is something that is going to be sort of like a slow rolling storm over a number of years. It's important to recognize that H.R. 1 was principally a tax cut. It is not a health care bill. H.R. 1 was designed to give tax relief or tax cuts to a wide variety of individuals. And it eliminated some tax breaks as well that folks will be feeling very shortly.
Yes.
Most of them hitting around January 1st. In order to achieve enough support in Congress for passage, the creators or authors of H.R. 1 had to basically find cuts in outlays to decrease the impact of these very, very substantial tax cuts. And where they found that opportunity to decrease government expenses was most importantly in the Medicaid program. When you look at where tax dollars go in this country, it's Medicare,
Social Security,
right. Medicaid, and the military.
Right.
Everything else is an extremely small percentage of federal expenses. And so with the promise to not touch the Medicare program, we could go into some of the nuances of that. Medicaid was one of the only substantial targets that could be cut as a part of this tax cut package,
right.
And decrease the impact of these tax cuts on the federal deficit. And that was something that had to be done in order for the bill's authors to get enough support, enough votes
yes.
To pass the bill.
And it worked. And it worked.
Mm-hmm. They got by. It was a close margin, but they got by. But it's not a health care bill. It's a revenue bill. It's a tax cut bill. And what we use as a shorthand for the impact on Medicaid, it was a pay for. It was a pay for in order to get the votes needed to pass this very, very expensive tax cut.
I haven't heard that term before, pay for, meaning it was sort of like, it was a tack on or it was a trade-off.
Well, the deficit was going to go up by this much.
Right.
And the politically tolerable increase in the deficit was this much. So we had to come up with a pay for.
That's interesting.
Yeah.
So when this was all being discussed before its passage in July, and when it was being debated and when it finally passed, it felt like a distant, I know it didn't feel like that to you, but for the average person, it felt like a distant unknown. This may affect us. It may happen in a year or two. Now we're really looking at it. We're really staring at, in the face. So how can you please explain how, you and your staff and the Dignity infrastructure is handling this? How will you handle these kinds of cuts?
Much still to be determined. There are two ways to handle a loss of revenue. You can cut services, you can cut expenditures, or you can grow. You can increase your revenues. We're looking at all of those, and we are looking at those because we are absolutely determined to continue to operate our healthcare facilities in California. We are absolutely confident that we will continue to operate Sierra Nevada Memorial Hospital here in Nevada County, and we will find a way to operate efficiently. We call that stewardship. We are the stewards.
I like that word.
It's an important word because we are the stewards of a very precious, important community resource.
It's unusual,
it's our responsibility.
Too, right?
It's our responsibility to take care of this resource and to make sure it's still there for Nevada County residents. Now, we have to examine every expenditure. We have to always ask ourselves the question, is this something that we need to do? Is this something that our community needs? And we have to look for opportunities to grow as well. Healthcare is still essentially a fee-for-service economy.
Yes.
And it's perfectly reasonable in that setting to say, how do we grow? How do we get more patients to come to us to improve our revenue situation? It's not merely a matter of hoping for assistance, hoping for a miracle. We have to make our business run
proactive,
just like any other business owner.
Of course.
We have to make our business run, and we will be working on every opportunity that we can see to make this business more successful so that we can successfully steward that resource for the people who live in Nevada County.
And we are quite lucky with a population of 120,000 people to have a hospital in our community. It's not every rural area with a population like that is lucky enough to have that kind of a healthcare facility.
Actually, very few rural counties in California have a resource that offers this kind of robust care.
Yes.
As you look north of us, there are certainly some great facilities north of us, but there aren't that many.
Right.
And there are large areas in Northern California that have pretty sparse resources in terms of healthcare. No, we are lucky. The people who founded this facility had vision. They were looking forward. And it's actually a wonderful story of a community that wanted to take care of itself. As I said, we consider it a tremendous responsibility to take care of this resource.
If someone comes to the hospital and through these cuts and these transformations loses their ability to pay, however, whether it's Medi-Cal or Medicare, they lose their ability to pay. I don't know the state law well enough, but when someone comes to you, is the hospital required to take care of them?
Well, let's first start with our mission. We're a mission-based organization. We're actually a community benefits not-for-profit. We're here to take care of the people in this community. Mm-hmm. We're never going to turn anybody away. Mm-hmm. Now, we are legally obligated to provide care for anybody who comes to us in need. We're obligated to do a careful assessment to determine whether they need urgent stabilization, and we're required to provide that stabilization. I think it's safe to assume that based on our mission as well as the law, we will continue to care for everyone who comes to us in need. And we actually consider that our purpose. That's why we're here.
Well, that's a relief. I mean, all of this is information that people have been grappling with and unsure about. I was wondering about the grant portion of the new bill, whether or not it's a grant specifically geared toward rural healthcare facilities, whether or not you would indeed be either eligible or would you be applying for this temporary grant?
So you're talking about the $50 billion rural health grant that was tacked on to HR 1. That grant it's interesting in its structure. At the present time, we don't know how or if it is going to impact us, because every state is entitled to a percentage, a piece of that money. It is applied for on a state-by-state basis. So the state of California is gearing up to put in an application for California's share of those funds. And that money can be spent on rural infrastructure. It can be spent on provider payments. It can be spent on training. And we don't at this time know how it's going to be spent, or if acute care hospitals are actually going to benefit, because, for example, much of the funding could go towards rural health centers or providers
like Chappadee or one of those.
Exactly. So we don't know how that money is going to be spent. It's very important to recognize that versus the revenue that's going to be lost for healthcare providers in California, it's a pretty small drop in the bucket. It's not going to make up for the lost revenue that rural health facilities experience as a result of HR 1. Obviously, we're going to make an effort, and we've given our views to the state of California as to where we think the priorities lie going forward. But we are going to be waiting to see how that money is going to be spent, how it's going to come to us, if it comes to us at all.
I know it's interesting because wait and see is sort of the hallmark.
There's a lot of wait and see
all
going
of this,
on.
right?
It's probably worth noting the structure of HR 1. The tax cuts hit immediately. The reductions in healthcare funding hit over a period of years after the tax cuts kick in. We have talked about the provider taxes, for example. California makes use of the provider taxes to provide extra funding to healthcare facilities that care for, we call it Medi-Cal, but those are Medicaid patients. And the bill specifically limited the ability of states to use the provider tax funding method to provide those supplemental payments. We will be directly impacted by that. We receive millions of dollars a year through that mechanism, as do many hospitals in California. It is a way in which we are partially reimbursed for the cost of caring for patients who are insured by Medicaid. I think that we've talked about this a little bit before, but hospitals and providers in California are reimbursed at significantly below their costs of providing care by both Medicaid and Medicare. And so these are actually going to be further reductions in our reimbursement for that patient population. It's going to increase the gap between what it costs healthcare organizations to care for those patients and what we're actually reimbursed, which is already a pretty significant gap.
Boy, it's a lot of moving pieces and a lot of, as you say, unknowns yet to be revealed. So we would love to stay in touch with you and get your input for how this, how this continues to reveal itself to the public. But I think the bottom line here in our conversation that I heard that a lot of people are going to hear is that the hospital is not going anywhere. So we thank you for that. We thank you for the service here in Nevada County, and we would love to have you back.
I would love to be back. The hospital is not going anywhere.
We appreciate that. Thank you so much.
Thank you.